And I'm Kim Willis, and I'm a clinical lead occupational therapist who works in West Wales in primary care. Yeah, well, I'm not a policy maker. I come talk to you about what it is like on the ground, really. So that's my bread and butter, is working in that primary care sector. So we very fortunate in Pembrokeshire, we actually pioneered some of this stuff in Wales when it came to having OTs directly working within GP practices. And what started off as a cluster-funded project grew and expanded. So we know as occupational therapists, we're very holistic. I'd say we're one of the most holistic. We're trained physical health, mental health, across health and social care. We look at barriers to function in everyday life, bearing in mind what someone's condition is, regardless of what their condition or conditions are, because obviously we're seeing more and more comorbidities. Looking at someone enabling to stay in their own home and doing the things that they need and want to be able to do. And I think one of the challenges we have as OTs, more generally, is the lack of understanding from other healthcare professionals what it is we actually do. We're really poor at defining ourselves. And I think part of that is because of that broad spectrum I just mentioned of where we can work, it's very hard to say this is what we do for everybody. I can tell you what I do for Mrs. Jones or what I do for whoever, but it's a challenging thing to define. But certainly within primary care, what we've found as it's expanded is that we are part of that workplace, and we are picking up patients within our service in primary care that would never meet the criteria for any other service in our region. So this, I think, is a really important point, because going back to that preventative work we're talking about, if we see the walking well, we see working age people who want to get back into work. There's an emerging role within doing fit notes and things. I know that physios are also as part of that conversation. So we are seeing people who are working or who are able to get about, able to go to the shops, able to live a life, but they're just on that cusp of tipping into something happening, and it doesn't take very many things to go wrong before someone's well-being and their independence and the way that they live their life alters. Through their own well-being and also and their own health, as well as factors around them, environmental factors as well. There is just so many ways that you have access to an occupational therapist. It's a minefield, and GPs don't know, and they say, Kim, I've got this person, what do you think? And then part of my role is to navigate some of that system, because that system is all about transferring care all the time, which we know is costly and time-to. And our data, does show that, in terms of the before and after when someone goes into a GP, into the practice, before they get seen by an OT versus after, our data almost unanimously says that reduces. So we're saving GP time. And that was always one of the very initial drivers for what we're doing is, well, can you save GP time? But actually, as time has gone on and as the project has expanded, we're now being recognised as adding value in our own right as an AHP, adding something different. So we're not doing medical model stuff. We're doing function, we're doing the other bits that the GPs don't know what to do with. So I think it's important to note that I agree with that focus needs to come straight back into primary care.